I'd now like to welcome another orthopaedic surgeon, Dr. Seth Tarrant. Seth is an orthopaedic and trauma surgeon at the John Hunter Hospital in New South Wales, who has an extensive research profile on fragility fractures. He's won many international awards and presented internationally, and he's currently doing his PhD in the physiology and epidemiology of hip fracture. And Seth's going to speak to us today about weight-bearing status and outcomes after hip fracture. Welcome, Seth.
Certainly a hard act to follow with the venerable Professor Costa, so bear with me. So no real conflicts of interest in this talk. So the objectives of this next 10-15 minutes is essentially understand what is weight bearing in the elderly. How does Australia perform, particularly in international context? Why does it even matter? You know, why are we so concerned regarding weight bearing? What is the evidence base that we can make our decisions upon, which will eventually help our patients? And ultimately, how can we do better on a patient-by-patient, day-by-day basis? So there's a lot of definitions. I know the physiotherapists left the building about 30 minutes ago, but they must get very frustrated by this. Full weight bear is tolerated, assisted weight bear, partial weight bear, etc., etc., etc. You either weight bear or you don't. And is any of these options feasible? Well, according to Kammerlander from Munich, probably not. This study had been performed before, but this is one of the more recent variations of the theme. They use pressure sensors in young patients. You see the blue graph is the non-weight bearing limb, and the red is the weight bearing limb. So you have this elegant description of the three rockers of the foot: heel strike, roll through, and push off. In an elderly patient with a hip fracture, this is the non-weight bear, this is the weight bear, and it's this graph says it all. Now, this is the entire talk. You know, we should never partial weight bear a patient again because it is impossible. But why do we do it? You know, can you restrict weight bear? No. And the conclusion was very firm by this group. There was no watering down of it. Post-operative partial weight bearing for these patients should be abandoned, not considered, abandoned. So how do we perform? Over the last 5 years in Australia, we've basically, despite this paper coming out and doyens of the hip fracture community, such as Professor Close, advocating for full weight bear, we still have about 5% of our patients have some sort of restricted weight bearing. It's not bad, but it's not perfect, and we have to exploit the margins in order to prove the care. Once again, registries generate a lot of questions, and we need answers for them. Just because 5% don't weight bear, what does this mean? On a hospital-by-hospital basis, we can describe it. You know, high performers at the top, such as Armidale and Port Macquarie. You know, but there's a lot of variation. I won't name the three-letter acronyms down the bottom, but up to 20% of patients are non-weight bearing or partial weight bearing in these hospitals, knowing that it's futile. There's probably a lot of variation between surgeons. I can safely sort of attest to that, and that occurs to education, what they've learned in their training. Technical tips and tricks, and also registrars being protected. And what we did, about half the patients were restricted weight bearing because the registrar was so afraid of their operation failing. And the consultant came around day 2, 3, 4 when the num's going, why can't this patient walk, and get them to rehab and say, oh no, they could walk all along. So there's many different levels where we restrict our practice. Now, Stuart Fleming, who's here today in the room, provided me these figures a couple of weeks ago because I was very curious about the breakdown. So even though we have restricted weight bearing, what does this mean? You know, and in the arthroplasty, for arthroplasty patients, looking at nearly 30,000 of them in the ANZ HFR, restricted weight bearing is under 2%, which is as you expect. And those 2% that are restricted weight bearing, what has gone wrong? Fixation, however, 7% of fixation in Australia has some sort of restricted weight bearing. So 1 in 14 patients, something the surgeon does not like or something hasn't been done correctly, and their weight bearing. In New Zealand, it's over 10% of all fixed hip fractures have some sort of restricted weight bearing. So the real evidence base. The 2017 guidelines from the UK, 664 pages, a complete tome of everything about hip fracture, being updated in 2023 if you want to understand. Recommendation, fully weight bear. Evidence, no direct evidence related to this recommendation. Of course, there's a lot of good evidence for early mobilisation, and is weight bearing correlate to that? Well, we make that assumption, but is that indeed the case? So we go across the Atlantic to the US. 5,000 patients, looking at their NSQIT database. This was analysis, adjusted weight bearing, non-weight bearing, adjusted for all these factors on the side. Patients who were full weight bear had less adverse events, less serious adverse events, major, minor, less delirium, less transfusion, less mortality. Game over. We shouldn't partial weight bear any patients. However, does this reflect our practice? Well, only 64% of this cohort was allowed to weight bear, and they excluded the 10% of the sickest patients from the analysis. So what's the external validity of this? Is this a population the same as ours? A year later, exactly the same database, another 3,000 patients showed the same thing, only 74% weight bearing. So how can I relate their practice to my practice? And in their analysis, they subdivided by fractures. 30% of their nails were non-weight bearing, 30% of their pin and plates were non-weight bearing, and the hemiarthroplasty, 22% were non-weight bearing. So I'm not sure what's happening, but can I use their data to support my practice? Well, the average surgeon would say, I don't know what they're doing, but it's not what I'm doing, so I'm not going to listen to them. Further breaking it down, fixation, improved, but hemiarthroplasty, there was no improvement. Weight bearing and non-weight bearing. So should we be non-weight bearing hemis? Does it matter? And mortality, there was even less impressive results. So there's a lot of mixed messages, so I thought I'd create my own in order to inform my own practice and try to convince my own colleagues in something that I believed in, which is weight bearing. And this started back in HipFest in 2018. As a registrar, I attended, and we had the Brown Butcher's paper, and we were writing down things we could improve. And the John Hunter Hospital, I had the registry results. I said, we can improve our weight bearing. But what do I make of that 5% figure? I did a causal analysis looking at the factors that affect mortality as the major outcome, the interplay between weight bearing and post-operative day one mobility, which was reported by the registry. And essentially, when looking at our own institutional practice, we looked at about 1,600 patients. We showed that the patients who were restricted weight bearing, in fact, younger, but nothing else was really different. There was no difference in comorbidities, cognitive impairment, residential care facilities, or pre-morbid mobility. This is where things got interesting, though. In terms of the patients that were restricted weight bearing, there was more displaced intracapsular fractures, which was suspicious. There was more subtrochanteric fractures restricted, which was also suspicious. More cannulated screws and more long nails. But that doesn't mean much to a surgeon, so I had to break it down even further. And this is where we go to the very confusing AO classification, which has 9 types of trochanteric fractures. And we demonstrated that this 3.3 pattern, the nasty reverse oblique, were the culprits, which the majority of our patients in our institution were non-weight bearing. Likewise, the simple valgus impacted fracture in the subcapitals was also the main culprit in the non-weight bearing patients. And what was the problem with weight bearing? Well, low numbers, large confidence intervals. We didn't really show any differences in mortality. We did show that those non-weight bearing had high DVTs. But with pretty small numbers, the chance of having a significant outcome was unlikely in the get-go. We also showed that restricted weight bearing didn't have much of a influence on the opportunity to mobilise day one, but the opportunity to mobilise on day one had a very significant impact on mortality. So how can we do better at the end of the day? So the registry informed us we're not up to scratch, but we need to obviously delve deeper, which is what I did, try to define the problem. And obviously in our institution, trochanteric fractures and minimally displaced subcapital fractures are of concern. And I'd probably hypothesise that if we looked at each individual institution in that registry, these would be the main culprits. So these are direct patients from our registry who are non-weight bearing and who had reoperations in 120 days. So these are sort of classical examples. So we look at this x-ray, think, it doesn't look too bad. 90-year-old, a bit sick, ASA4, give him a quick operation. Look at the lateral, is it off the back? Hard to say. Terrible lateral, but a classical one. Gets cannulated screws, yeah, it looks all right. Yeah, as we'll hold up. Now, 60 days later, has another operation. Increased risks, more surgery, more cost, etc., more pain, etc., etc., etc. Another example, once again, 80-year-old, demented, nursing home, quick operation, can't really see what's off the back and lateral, get a CT now, should be sweet. Operation probably suboptimal in terms of screw placement, but that's a technical matter, it doesn't matter. And of course, falls apart, another operation. So should we just do an arthroplasty for these? And the answer is probably yes, and we do have excellent data. Now this is a sub-analysis from the health and the faith trials, and many hospitals globally participated, including some hospitals in Australia and certainly in Melbourne and in Queensland. And essentially they compared 2 different RCTs. They compared the patients from the faith, which was cannulated screws versus DHS, compared with the displaced fractures, so you got hemis or total hips from the health trials. So the FAITH patients were actually younger and fitter from surrogates comorbidities. And in the end, internal fixation had a higher mortality at 2 years, had a higher reoperation rate. And this is for non-displaced or minimally displaced fractures, and their physical quality of life scores were worse as well. When they subdivided it into quartiles for mortality, certainly the sicker patients performed far better with arthroplasty. So sicker patients died with fixation, you could safely say, from this cohort, or two cohorts, and let alone the higher operation rates and worse quality of life. So does this mean we should replace all minimally displaced fractures? Well, probably not, but from those studies, they show that the older and obviously more benefits. So this is one of my patients 6 weeks ago, 75, pretty fit, plays golf, minimally displaced fracture, good lateral. Do I replace this? Well, probably not. I think this fixation can still be used in some patients. But what about when arthroplasty isn't possible? We can't bail out every case with a hip replacement. And this was the other culprit, the 3.3 intertrochanteric fractures. Obviously, we ideally fix these, and it's ideal to do fixation relatively well. As one of my x-rays once again from 6 weeks ago, that screw is a little bit posterior, to be critical. But we can't replace this, so we just have to fix them. And is there evidence for fixing these in full weight bearing? Well, unfortunately not. Some papers look like they're going to answer the question, but this paper from some doyens of the orthopaedic trauma world in the States, and Robert O'Toole from Shock in Baltimore and Claude Sagi from Cincinnati, looked at this question in subtrox, but however, this cohort was younger than our hip fractures. There was more males than our hip fractures, and it was a high energy. And at the end of the day, they showed a decreased length of stay, but nothing really much else. We looked into unstable nail fractures, and John Hunter looked at over 600 patients. We showed that this 3.3 pattern was not associated with increased failure rate, and the majority of, all our failures, in fact, were full weight bearing, with very few of the non-failures non-weight bearing. So it's really poorly studied whether we can weight bear this type of fracture in the elderly, and poorly studied, including by myself, adding to the retrospective literature. And failure rates are pretty low. That's hard to study and hard to define that as an outcome. The median failure time is at 3 months, 3 to 4 months, which is well and truly outside the restricted weight bearing zone that we often impose on patients. So going back to the UK, the GIRFT or GIRFT, however you pronounce it, getting it right the first time. I think at the end of the day, this should be the message for 3.3s. We don't have very many options except for fixing them, so we have to do it properly. This is a patient I inherited in early September, with this classic 3.3 patterns. Had fixation. There's certainly some signs of struggle in there. The fact they put foot and ankle plates on a trochanteric femur fracture raises alarm bells. They were in bed for 6 weeks non-weight bearing up in the peripheral hospital before they were referred down to us. I unfortunately was on the day and inherited them. Getting it right the first time would have been far easier to do. I had to revise it. It doesn't look perfect. 6 weeks down the track, she's weight bearing on it. But I was just lucky that it wasn't infected, let alone the potential of this failing, which is quite high. Getting it right the first time, I'd advocate any patient that is not full weight bearing is a surrogate for something that's gone wrong with surgery. I think as a surgeon, you should not leave the room until you are happy to full weight bear a patient. And if any patient is non-weight bearing, you need to address your surgical team and ask them, why are they weight bearing? Were you happy with the procedure? And if they weren't happy, then maybe you should explore reasons why. There's plenty of techniques that you can do to percutaneously reduce fractures and allow full weight bearing constructs. So in conclusion, Australia's at 5% non-weight bearing. We're better than some, but not optimal. We have to reflect about why our fixation isn't full weight bearing, how we can do better. Weight bearing certainly doesn't do harm. It's easy for me to go up here and say we should do better, but we have to get it right the first time, and we shouldn't leave the operating room until you're happy to let the patient weight bear. And at the end of the day, this is a case-by-case, local basis, and we need to have frank discussions and be open in our centres to make sure we can improve the quality of care for weight bearing. From little things, big things grow. Thank you.